so many people are just sitting here unaware that they're really one hit away or one problem away from having a significant health crisis. And what I'm going to cover today will help us demystify why some people already are struggling with long COVID. So most of the labs that I'm going to go over today are actually patients that I work with that have long COVID or were diagnosed with long COVID. Some of the labs are just people that were very vulnerable to COVID or had a vaccine injury instead. So this is not a small thing. There's a tremendous amount of people, you can see it all over the news, obviously, but there are people already that have chronic fatigue syndrome, myalgic encephalomyelitis. And so they've been through this for a long time. Some people have been through this for decades already. And now you have this new crop of people that have had COVID or were vaccinated for COVID, and their life isn't the same. Okay, so this is a huge amount of people. And we're going to cover some pretty straightforward labs that people can run. Most of them are inexpensive. For example, a CBC with differential I can get for around $12. All right, so it's not necessarily expensive testing we're going to cover today. If you're a clinician, then I'm so glad that you're here, because I've developed a framework that I think is super helpful in approaching long COVID. It seems to be pretty straightforward, and patients understand it when you explain it to them. If you're a client or you're not a clinician, the goal today isn't to get too technical with everything, but I'm going to get a little technical because some of this is actually technical. So without further ado, let me just dive into it. At the end of the call today, or at the end of this webinar, we'll be doing a Q&A. So I'll talk for about 45 minutes to an hour and then do a Q&A at the very end. So let me share screen here. That isn't what I want to do. All right. So if I hit play, then that means that I might lose the Zoom. So I'm not going to hit play. I'm just going to go to the next slide. Here's that wonderful drawing that I did. I got some good feedback on this drawing. And evidently my penmanship has improved over the years. But this is kind of the basis. So if you were at the first long COVID webinar, we talked about the 6 loops of long COVID. Now, listen, it's just a framework for a clinical approach. There's definitely more involved than 6 things, but we have all these people that are struggling right now: fatigue, neurological symptoms, cardiac symptoms, digestive symptoms, emotional issues. They have so many symptoms. The symptoms just basically are running amok, right? And then underneath those symptoms, we have 6 loops of long COVID that we can kind of point to as kind of pivot points in their case as far as evaluating what's going on with them. And then history and exam and labs will tell us what is actually driving the 6 loops. Does that make sense? So we get a kind of a checkpoint of where they're at in these different systems. And then we actually can use objective data, history, exam, labs, diagnostics, forms to really determine what's going on with that particular person, and then figure out what we're going to do for them that's specific. There's really no protocol that's going to work, and there's no one lab test you can run or one exam finding that you can do. There's not one genetic test you can run. It's really a constellation of findings that becomes their formula for success, as it were, as far as case management goes. Now, if we look at this slide again, all right, what are the 6 loops of COVID? Let's just call it mucosal symptoms hang around. So the virus enters through the lungs or through the stomach. People tend to have inflammation in their mouth, in their sinuses, in their nasopharynx, in their esophagus, in their stomach, in their lungs, anywhere the virus touched initially. And then we can just add to that basically the mucous membrane. So also besides the GI, vaginal issues, bladder issues, things like that. Okay, so we have lungs, sinuses, throat, esophagus, stomach, GI system, bladder, genitourinary system, and vaginal area. Okay, those are all different areas that could be significantly impacted in loop 1. And we're going to talk about some lab findings that go with that. Okay, loop 2 is the mast cell issue. That's mast cell activation syndrome. Loop 3, and that's going to lead to a lot of histamine issues, or histamine issues can also lead to the next loop, which is neurogenic inflammation, which I discussed in great detail in the second video. The next loop is related to fibrosis, basically accelerated aging, accelerated neurodegenerative process, neuroinflammation, scar tissue formation, keloid scars, immunosuppression. That's loop 4, fibrosis. That means there's no getting that tissue back to healthy tissue. That tissue is now permanently altered into aged, older tissue that won't come back. Loop 5 is chronic infection or reactivation of infection. And then loops 6 is the autoimmune, either new autoimmunity or flared autoimmunity. As part of neurogenic inflammation in loop 3, we have POTS, migraine, stress chemistry. So that's anxiety and depression, brain fog. Okay. And so these show up differently in exams. They show up differently in histories. They show up differently in symptoms. They show up differently in labs. And so the purpose of today is against on the labs. So if we just look at section 1, which was the GI or the mucosal areas, so lungs, nasopharynx, throat, etc., we start just looking at some things that could happen there. This is a client who had a persistent mucus situation after they got COVID. And so we did a swab of their nares, and we see that they had Staph aureus, large amount. So Staph aureus does belong in there, okay, but it's way too much. And so basically this would be fitting the category of, yeah, their key symptom is mucus, and it's so bad that they can't sleep at night because it's just draining all night. They can barely work, they can barely breathe. But also technically this is not an infection, but this is an overgrowth. So this would be an example of a lab test that you can do. And it's pretty straightforward. You just swab their nose and then mail it in, and then we have the results in a few weeks. This person was also swabbed for fungus and mold, and they came back normal on that. Okay, the next person, here is a situation where they did a stool test. Okay, now this person does have, you can see over here, high secretory IgA. Basically, secretory IgA is the immune system that's in the lining of our skin. Basically, it's on the surface of our skin. It's on the inside of our nose. It's on the inside of our mouth. It's on the inside of our intestines. It's everywhere that there's a lining. And so basically, SIgA can be depleted if we're really stressed, but it can be increased if we have inflammation at the lining of the mucosa. If you've ever eaten something and like you get that white film on the inside of your cheek and it just kind of sheds off, that could be an example of a mucosal inflammation. And you can get mucus also in your stool from stuff like this. But basically, this person has elevated secretory IgA. You can see they have bacteria and yeast elevation. You can see that they're low in short-chain fatty acids, which is super important for microbiome diversity, also helpful for neuroinflammation. And then they also had an infection. Now, this person also consumes around 20 alcohol beverages a week. So, you know, sometimes people will just go and they'll get their labs treated, and then nobody ever talks to them about their lifestyle. You know, we wouldn't be successful at all in dealing with this mucosal inflammation without dealing with the alcohol. So that was just something to note. Now, in the parlance of the loops of COVID, this person has a mucosal loop here. Okay, even though it's only one, it is elevated on secretory IgA. They do have a infection. Okay, so that would be considered loop 5. Okay, and then they have a vulnerability to autoimmunity because of this lack of microbiome diversity. Now, if we look at their cortisol awakening rhythm, so these aren't really standard tests, but this next test on the right-hand side here is basically looking at cortisol. We talked about stress chemistry and neurogenic inflammation as part of the loops of COVID. And so here's a person that when they wake up in the morning, they have basically no cortisol, but then it goes up kind of outside of the optimal range later in the day. And then on the left box, this square here is basically when they wake up, their cortisol is 0.335, but then it drops to 0.037 by 7. So that's a paradoxical response. This is what's called a cortisol awakening rhythm. You ever heard somebody that has a really hard time getting up in the morning? What happens in the morning, once we wake up, within that first 15 minutes or so, 30 minutes, we're supposed to really have an elevation of our cortisol. And so this person is dealing with some depression. This person's dealing with some memory issues. This person's dealing with some immune regulation. And basically their brain cannot regulate cortisol, and that's going to create some significant problems for them. That's kind of an interesting test. So what we did here was a salivary cortisol test. This is actually run by another clinician, but I just did a case review for this person. The same individual has escalated. Okay, so now you can see that their morning cortisol, we already knew that was low. So this is a blood test. So morning cortisol is low, and then they have low red blood cells. Basically, they can't deliver oxygen to the brain, which is going to make their brain fog much worse. So this person is dealing with brain fog, tooth pain, significant pain all over their body, significant anxiety, and without oxygen in their brain, you could see how that would make somebody a little stressed, right? Now, they also have low thyroid function. It's really impossible to heal if your thyroid isn't working, and they have autoimmunity. So in the parlance of long loops of COVID, we have an autoimmunity, we have stress chemistry issues, we have metabolic issues, which isn't really even covered, but then we have lining of the intestine issues. And so this person has several loops of long COVID. And by the way, if you look at this slide over here on the right, they have low CD57. That's basically natural killer cells. So one of the loops of COVID, we talk about increased infections and vulnerability to blooming out of old infections. So this person had a blooming out of Lyme and a blooming out of Epstein-Barr as a result of all the stuff that happened. Now, he had Lyme and he had Epstein-Barr way ahead of getting COVID or getting vaccinated for COVID, but he didn't tolerate the vaccine very well, and he didn't tolerate COVID particularly well, or a mysterious infection that he had in December. Basically, when you have this type of natural killer cell activity, natural killer cells are what are called innate immune cells. They're white blood cells that are basically floating around in their blood, and they're like sheriff deputies. They can do a lot of different things. They're like law enforcement inside of our body. They're trained to do several different things, but there's only so many of them. One of the things they do is they can kill cancer cells. So having a low natural killer cell can make somebody vulnerable to cancer. And this person did have a squamous cell carcinoma that they had taken off their nose. Another thing that natural killer cells do is they kind of help us stay on top of infections. So imagine that if you had chronic Lyme, this would help make it more chronic. Okay. Now, did you know that when you have neurogenic inflammation, or when you have some of the cerebellar issues we talked about in video 2, that you can have apoptosis of these natural killer cells? And so what that means is that the brain issue causes these cells to die just by there being a brain issue. So this is where we can get into the neuroimmune aspect of managing a case with COVID. Now, the goal today isn't to really get into comprehensive case management and what I did for these individuals, but to really just show you that you can absolutely spot this stuff. It's right there. Okay, the next case. Here's another individual who had COVID. Okay, now these labs were taken before they had COVID, but I wanted to point this out because it's super important. You see this person has low SIGA right here. So this person was just a sitting duck to have a bad reaction to COVID. Luckily, they did not have a bad reaction to COVID. They took a bunch of vitamins and herbs based upon kind of a framework or approach that a colleague of mine, Dr. Sam Yannick, and some colleagues put together. It was a nutritional approach to phases of care of long COVID, and he did very well with that. But you can see that he had vulnerability to things in his gut, basically getting into his bloodstream. And then he had this occluded and zonulin means that he had leaky gut. And the LPS means he had an infection or overgrowth in his gut. So he had such significant issues with his digestion that he was basically on a carnivore diet, and that's what worked best for him. And when we see these kind of things, we know that because so much of their immune system surrounds their intestines, they're more vulnerable to autoimmunity. But for him, you can't really do much more of a restricted diet than what he's already doing. You couldn't do any fiber. He would just fall apart if he had fiber. But the thing that worked for him was managing things that helped LPS and things that helped histamine release, okay? Because he was reacting to everything that was going into his bowel. He was having histamine reactions to the infection in his bowel. And so when we stabilize his mast cells, he got the biggest improvement from that, which is loop 2, okay? So this is the interface of loop 1, which is mucosal lining, loop 2, which is mast cells. And we could say that because he has occluded zonulin antibodies, that he's shading towards autoimmunity, which is loop 6. Okay, now this is something that I see all the time, starting in the parlance of bladder type stuff. And basically, remember we said any internal lining could be a problem. Man, listen, we all have heard, maybe not, but most of you have heard of like grandma or grandpa, they get that bladder infection, and then all of a sudden they're in the hospital from that bladder infection. And let me tell you, these bladder infections, they just don't start when they're in their 60s and 70s. And the more I do labs, the more I can appreciate as baseline testing how many people have these hidden bladder issues. And so they have these bladder infections, or they have these bladder overgrowths. And this person actually has evidence of a bladder issue. This is actually the slide that shows that. So we see white blood cell esterase, occult blood. So this person actually was getting some bleeding, and it wasn't from her period. Okay, and then there's the white blood cells and red blood cells in the urine. Now, this person also has acute inflammation. And this person at this point in their life did not have COVID, okay, but they got the J&J vaccine, and within their first period of J&J, they just kept bleeding, okay? They just kept bleeding. So this is not a COVID issue, but this could be related to a COVID vaccine. But the acute inflammation, the C-reactive protein, is one of the markers that's so important when we start looking at autoimmunity and new autoimmunity. This means that there's an active bonfire in the body, and we need to do something about it. Did this person have any bladder symptoms? No. Okay, so it's just sitting there waiting. Now, she's 39 at the time, she's 40 now. By the time she's 60 or 70, if this doesn't get dealt with, she's just having excessive acute inflammation. It's systemic. When you get acute inflammation that's systemic, you can see here the relative risk for cardiovascular event. That's kind of a scary thing that's to point out, okay, to folks when they read this. But basically, this person's risk of a heart attack or stroke is high, ongoing until that's resolved. Okay, so that's a really important marker. C-reactive protein really ties in with loop 6, which is autoimmunity. It also could be elevated in infection, which is loop 5. And C-reactive protein also is a significant cardiovascular marker. So one of the things that happens to people as they get older, they end up in the hospital with like delirium, or like their memory just gets shot. They miss their exit, you know, they can't drive anymore. They get in a car accident, they go to the hospital, they do a diagnostic on them, and then they're just told they have a bladder infection and that they had delirium or acute onset dementia from that. But listen, it would be cool to deal with this at 40 instead of letting this go run amok for 20 years. Now, the other thing about this is that the same immune system that attacks infections in hollow spaces or overgrowth. So if you have a bladder infection that's chronic, but it's not giving you symptoms, but your immune system is constantly trying to fight it, the type of immune system that fights infections in hollow spaces is the same type of immune system that carries out autoimmunity. So it's just really important to deal with these things. So that's just another example of a mucosal type loop 1 and a loop 5, which is a chronic infection, which could turn into autoimmunity. At this time, that person didn't have autoimmunity, but they did have some neurodevelopmental issues that was manifesting as dyslexia. Okay. Next case. All right, this is an individual who is in their 40s. They work at their desk in front of a computer all day doing design work. And you can see here, now, one of the things I want to point out about lab testing in long COVID or in any functional model or any, let me just, how do I say this? Lab testing, a person might go to a doctor and you can see that this result flag over here, they all say normal. You see that? It's all normal. All right. And so that all normal thing, you know, a doctor might just look at that and go, okay, nothing going on here. Or if they have an automated system, when it gets put into their automated system, like I use a system called Charm. And so if I do labs from LabCorp and LabCorp automatically interfaces with Charm, it will say normal on it. Okay, so this lab is technically normal, but this person can't look at a screen for more than a few minutes. Sometimes, you know, when he's really flared up, more than a few minutes, but he might be able to go a couple hours if he takes days off. Now, he's on a work leave, like so many people that have long COVID, they're unable to work. This is a guy in his 40s. It's during his peak time of his life where he should be doing awesome design work. And right now he's taking time off from work and he's not sure when he can get back to it. So it's like pretty significant. Now, if he goes to his doctor and his doctor looks at this and says, this is normal, then, you know, there might be some issues there. Okay. Now, this is where you start getting into the nuances of some of this testing. And so I don't want to spend too much time on this. Okay. But if you all just like look down here where it says neutrophils, neutrophils is another type of white blood cell. It's about 80% here. Now it's supposed to be no more than about 63%. Okay, so although his white blood cell count technically is normal, the percentage of neutrophils is way higher than it should be. Neutrophils actually are the types of white blood cells that go into tissue and wreak holy havoc. Okay, and you want that if you have an infected tissue, but if you have an autoimmune tissue, you don't want that. If you have a healthy tissue, you don't want them going in there. Now, do you see how this percentage, if we just look at the standard range here, you see all these, there's a standard range all the way to this is blank now. Okay, why is that blank? Well, what they do basically to get the standard ranges to know if it's flagged or not flagged, they take the average of everybody doing testing in the area, and then they go 2 standard deviations from the mean, and that basically gives you your ranges. And if you're outside 2 standard deviations, and there's some exceptions there like cholesterol and so on, but basically if you're outside 2 standard deviations, that's how a lot of labs, standard labs will look at things. That's why it's called standard range. And it's really based on who's doing testing in your area. Now, who's doing testing? Healthy people or sick people? Okay, so you can see how the standard ranges are already biased towards an unhealthy population. And so within that standard range, there's an optimal range. And that's what so-called functional medicine doctors do. They'll be looking at what's the optimal range, and it's called a functional range. And so those ranges are kind of based on physiology texts. And so those ranges are important. However, this individual, they're flagging as normal. And we go back to this area here where we say there's no standard range. Well, this is the part where I say when I was a young buck in chiropractic school and we were looking at labs, there used to be ranges for this. Okay, but there's no longer ranges. Well, why is that? Okay, well, there's no longer ranges for percentages of white blood cells because our white blood cells in the United States have become so screwed up that we can't give a standard range. Okay, it used to be that around 58 to 62%, and I'm old enough to say that now, it used to be that this was 58 to 63%. Now we don't know. Okay, but luckily we can remember, we can look back. Je viens de, right? I remember, I will not forget. Okay, and so basically we're going like this. What's optimal here? And this is definitely not optimal. This person has acute inflammation that's infiltrating tissue, and that's part of why he feels so bad. Now, his chief complaint, he's having muscle loss, he's having brain fog, he's having vertigo, he's having dizziness. Okay, he's having all these symptoms of concussion, never had a concussion. Now, if you look at his white blood cell count, you can see it's also on the high end of normal. It's not normal, folks. This should be around 6.5 optimally to maybe 7.5, 8. Okay, if it starts shading above 8, in my opinion, this looks like it could be an infection or some sort of acute immune-based issue. So this is how an infection or long COVID can hide in plain sight. Now, if we just go a little bit further and just go back to this for a second. Okay, this is loop. This would be loop 6. This would be an activation of an old infection, or this could be like a significant autoimmunity that's starting to happen. But basically, this is immune activation. Okay, now look, he's got total IgE. IgE is a type of antibody that we make. If we go back to this slide up yonder, okay, total IgE, think of mast cell, think of Th2, this little loop here. So that's the loop between something ticking off the lining of your body and a bunch of mast cell activation, or potentially B cell activation, or what's called Th2. So without getting into the major immunology with everybody here, for those of you clinicians, you know exactly what I'm talking about. If your patients, just know that if you have high IgE, that means that you've tipped towards a polarization pattern in your immune response, and you're a sitting duck for autoimmunity, you're a sitting duck for food sensitivities, you're a sitting duck for chronic infections, and you're a sitting duck for long COVID. Okay, we can also see here that this person has high CRP as well. Now, this lab has a different range. He's barely over, but he's over. And so basically he has acute inflammation that's immune-based in his body. It could be infection. It likely is infection. He doesn't necessarily sweat at night. He doesn't have swollen lymph nodes. It's not 100% clear where it is, but there is some evidence that he might have a sinus issue going on. So that might be something that we pay really special attention to in the first phase of his care plan. This is basically hot off the presses. You can see here, and I haven't started managing this case yet. In fact, we have a consultation tomorrow. Okay, this same individual has high MMP9. This is matrix metallic protein 9. Basically, if you imagine like, gosh, I was trying to think of this the other day with the same patient. So what's that movie where like the movie Medusa's in it, and it's like an old movie from the 80s, and there's this guy over there, and like he's trying to walk through a courtyard, and suddenly the statues come to life and they have spears. I don't know if you remember that or not, but basically it's a pretty cool movie. Anyway, if you imagine these white blood cells that are basically tucked inside tissue, and they're silent, they're just sitting there, they're not doing much. Okay, they're actually bound to the wall of the tissue by something called endochinase, okay, or endokinase, depending on who you ask. And so basically, when they get the signal, okay, when the signal is right, so in the movie, when that guy walked through the courtyard and he wasn't supposed to be there, these statues came to life. Okay, well, when there's tissue inflammation from infection or white blood cells have infiltrated the tissue, these guys break free from their chains, and then they basically grab onto whatever it is. So if it's the virus or the bacteria or that piece of tissue damage, and then they have to burrow out of the tissue into the blood so that they can, or into the lymph system, so that they can now deliver this piece of tissue to the lymph node and figure out what they're going to do about it. And so when you see elevated matrix metallic protein 9, you know that this person's undergoing a significant amount of immune activation. So we can now look at a CRP and go, yeah, okay, there's immune activation. It's acute. We look at his MMP9, we can say there's active tissue damage happening right now, probably in the early phase of that. And he also has elevated white blood cells that are a little bit more than normal and high neutrophils. Gosh, that looks an awful lot like an acute infection that really needs to be managed. Now, if he has autoimmunity at the same time, that autoimmunity is going to be made worse, usually by an acute infection. Not always, but often it is, especially if it's in a hollow space. Because remember, the infection in the hollow space, the immune system that attacks that is the same immune system that can carry out autoimmune attacks. And they work in tandem with neutrophils. Right here. Okay, so that's kind of a really significant case. Now he's got Th2 polarization. He's got active tissue damage. It sounds like he may have an active infection or a chronic sinus issue. I believe he had sinus surgery. He had some issues going on there. And he's got neurological symptoms. Okay, so he's got stress chemistry from that. And he can't look at a screen without like really getting anxious, dizzy, or basically the light in the screen is making it impossible for him to work. Okay, so that's what that case looks like on labs. That's what the loops look like for him. Okay, if we go to the next case, we talked a little bit in the first two sections about stress chemistry. When I say first two sections, I mean the first two videos. By the way, I know I'm talking like the Micro Machine Man, but I do have quite a few slides I want to get through, and then I want to be able to take questions. Okay, so imagine you sweating all the time, having terrible memory, gaining a bunch of weight around the middle. And basically, all your doctors are just basically telling you it's normal, have incredible anxiety. So this individual was traveling. They got COVID while they were on vacation. They had to shelter in place while on vacation. They came back, and this wasn't the first test I ran with them. Some baseline tests we ran. Basically, I looked at her white blood cell count. It actually looked pretty normal. You can see that she had elevated MCV, which means her red blood cells are too big. It means she can't oxygenate her tissue. And so she's going to be constantly in stress chemistry from what's called macrocytosis. So that's not really the point of the slide, but that's still a very significant impediment to her healing process. And that's going to make all of her stress chemistry worse. And it's going to make it hard to resolve that. And it's going to make it really difficult to resolve infections and have a normal brain function when the cells are too big to oxygenate the brain. Okay, but here's another case. where you have that bladder infection, okay? And this patient, it's like been the bane of their existence. So I'll send them to the doctor to get treated for a bladder infection, and then the doctor's like, we don't see it, we don't want to treat it. The stuff that we're doing isn't necessarily working in a functional model with probiotics and herbs, but this bladder infection is keeping the autoimmune dream alive. The autoimmune dream alive is keeping the immune signaling alive. That immune signaling is activating her brain, and it's causing stress chemistry. That stress chemistry is causing a significant cortisol issue. That cortisol issue is now opposing insulin. Cortisol is a stress hormone released from the adrenal glands, and it causes us to dump stored glucose. So it increases our glucose levels, whereas insulin decreases our glucose levels. This individual's on keto, and if they go off keto at all, basically have anything with sugar or starch at all, their blood sugar can easily go over 160, 170, 180, and sometimes it can take days to come down. So basically, they're on their way to diabetes. We've done testing with her in the past, and she did have autoantibodies to aspects of her pancreas. She did not have antibodies to aspects of her adrenals. So this could be an expression of adrenal autoimmunity, not technically Cushing's yet, okay, or excuse me, Addison's yet, but it could end up being Addison's. And we did go back and go back to the doctor and see if we could do a scan to see if there was a tumor or something like that happening. And so they've just decided that her results are not high enough to warrant any of that investigation yet. And she is starting to feel a lot better. We've done some things to help her manage cortisol with supplements, and we did some intensives with her, and her anxiety came down. She's back to work, okay? But basically, this is a case of high stress chemistry. We know that that high cortisol does what? One of the things it does, if you've ever read The Biology of Belief, Dr. Lipton talks a lot about what stress does to the brain. It basically acts like a tourniquet to parts of our brain. It keeps us in fight or flight. So imagine a person with a memory issue now pulling blood out of the frontal lobes. What's that going to do to your memory? What's that going to do to your sleep? And of course, we know what cortisol does to the immune system. It suppresses it. So is that going to help her get over her bladder issue? It probably has a lot to do with the idea why none of the herbs that I've given her helped her resolve the bladder issue, right? And then what else happens when you have impaired blood flow to the brain is that part of the brain, the dorsolateral prefrontal cortex, for example, is very sensitive to that. We saw with her saccadic latencies. That was something I talked about in the last video, okay? So these things all snap together very well, but she could not lose weight, even on keto. She was having weight gain around the middle. And so basically, this is the interface of stress chemistry, chronic infection, mucosal issue, and then we talked about her case a little bit in the last brain seminar. But this is what that would look like on labs, okay? Now, if you looked at this white blood cell count, her white blood cell count does not look like she has an infection. Her neutrophils and her distribution here, even though it's now not established, this to me looks like really nice in the functional range. So if I was to look at her white blood cells, I'd be like, wow, I don't really see any issue, okay? But if we look at her urinary testing, we definitely see an issue. And if we look at her stress chemistry, we definitely see an issue. If we look at her brain, we definitely see an issue. And if we look at her blood sugar, we see an issue. Now, in addition to that, her cholesterol is not very good, okay? Now, keto typically, when done properly, can lower cholesterol. Keto with too much saturated fat can be a problem. Now, listen, she's not eating carbs, okay? But she's eating saturated fat, and she's getting insulin surges from the high cortisol. So essentially, even though she's not eating sugar, the cortisol is causing her to secrete insulin, and the insulin is oxidizing the fat. And so she's still getting some of this bad cholesterol stuff because we haven't been able to get over on this immune thing. So although keto is working for her, it's not really helping her cardiovascular risk at this time. But if she goes back on starches, it would be worse. Now, this individual was asked to go on a statin, and the statin basically wrecked her. We'll just say that. Now, the statins don't wreck everybody, and certainly a cardiovascular risk is not something you want to just keep going. There's like 12 different theories of cardiovascular disease. The cholesterol model is one model. You definitely don't want a total cholesterol to good cholesterol ratio here above 5. And so it wasn't like bad advice to say go on a statin, but it completely wrecked her. Okay, so what can we do? Okay, all we can do is try to modulate her cortisol we work with her brain to see if we can get her brain to start monitoring and modulating her stress chemistry a little bit better. And so now that we've done successful things with her brain, in fact, we did something called transcutaneous vagal stimulation to help her brain. I'd be really interested to see what her cholesterol looks like and her cortisol numbers look like, because she's back to work, her memory's a little bit better, and she's definitely functioning at a higher level. Okay. This person does not have elevated TGF-beta that's suppressing her immune system, that's causing her to have an infection. So we ruled that out. But you can see here, there's another blood test. They totally messed this up at the lab. Okay. They totally messed this up. They didn't do the right test. Okay. But they did take her cortisol first thing in the morning. You can see that it's elevated. So even in a blood test, it's elevated. This test right here is they collected urine for an entire day and it was elevated. Okay. Now the doctor just didn't think this is elevated enough to warrant a CT scan, but it's still something that we're monitoring. Okay, moving on to the next case. Okay, this is a consult I did today. Okay, now this person got COVID, I believe, in 2021, and then they got vaccinated last year. And after I don't want to say which vaccine it is, okay, but they got 2 vaccines. And basically their bones just started melting. It's the best way to describe that. So she has avascular necrosis in her left hip. She has a compression fracture in her spine. She has what feels like fractures in her wrists. She's incredible amount of pain. She's waiting insurance approval on an MRI so that she can get further treatment for her back injury. But basically she's been in significant pain since the fall or the summer of last year. And so we look at her white blood cell count, it's high. This looks like infection. Okay, look at those neutrophils, extremely high. They're actually outside of lab range, and then our alkaline phosphatase is low. Well, gosh, it's really tough to fix bone when your alkaline phosphatase is low. I commonly see this with celiac, also lowering alkaline phosphatase. Celiac is an autoimmunity that can cause your immune system to attack your brain, and 3 out of 4 people with celiac, or 1 out of 4 more your intestines. Okay, so that's a significant autoimmunity. So my theory in her case is that she has a autoimmune bone disease, and we're going to confirm that with the test called Cyrex-RA5. She's going to get a DEXA scan. We could also do a urinary test to see if she's actively losing bone. I think it's glucose 6-PD or glucose 6-phosphate. I might be getting that mixed up with another test, but there's a urinary test to actively look at bone loss. And so anyway, this is just a consult that I did today, but this person definitely has either long COVID or a vaccine injury. And that's an immune-based thing. Okay, so we're thinking this is loop 6. Her acute phase reactants were normal though, so she didn't appear to have like acute inflammation, despite the fact that she has white blood cells and neutrophils. Her ferritin was not tested, so she could have other acute phase reactants, meaning there might be other tests besides CRP we can look at to look for acute phase inflammation. Okay, so with her, you know, we're actively exploring some things that's going to calm down her symptoms. She did say the thing that helped her the most so far was aspirin, even though steroids did almost nothing for her. So that's again lending to a little bit of an acute inflammatory issue. What aspirin is going to do is it's going to affect neutrophil influx into tissue. It's also going to affect something called prostaglandin E2, which can be pro-inflammatory. It's called an icosanoid. Okay, let's move on to the next one. And I'm going to summarize this at the end, everybody. Okay, these are labs that are basically these people are sitting ducks for infections. So you can see that their white blood cell count's lab low. They're also at high risk for cancer when the lab white blood cell count is low. You can see this person has dull lymphocytes, so their natural killer cells are probably going to be low. The types of white blood cells that make antibodies are going to be low. So here's the deal, like they go to the lab and they run antibody testing and they're told that they don't have autoimmunity. Well, no kidding. They may even have been told earlier in their life they have autoimmunity, and then they'll run antibody tests and their doctor will say, oh, you're in remission because you don't make antibodies anymore. Well, not so fast. Their white blood cell count's low. They can't make antibodies. Okay. So like, don't be the doctor that is diagnosing based on one lab. We want to be the doctor that understands the full breadth and depth of their case and can actually walk through it with them so that we don't tell them that they're cured of autoimmunity, which is impossible, by the way. And then they're just completely fluxumed as to why they feel so terrible with long COVID, even though they have all of their autoimmune symptoms flared up. So this individual really is likely to get an Epstein-Barr flare out. If they have Epstein-Barr, they're likely to get a cytomegalosis flare up. If they have that, they're likely to get their sinus issue to flare up. They're not going to be able to get over on their chronic Lyme issue. Now, remember we talked about how stress chemistry and brain issues like the cerebellum, like balance testing, finger to nose, could suggest there's a cerebellar issue that can cause apoptosis of white blood cells. Well, gosh, what if they have this? What if this person had POTS and this person had vertigo and this person couldn't even take any supplements? What are we going to do? Well, we're going to work with their brain to see if we can get their brain to stop killing their white blood cells first. That's what we're going to do. Okay. But what if this person has zero neurological symptoms, has like significant, let's call it thyroid autoimmunity, Hashimoto's, or celiac disease, or rheumatoid arthritis, which have more of what's called a Th1 endotype. Okay, meaning these white blood cells, these neutrophils that are 76% and should only be about 63%, they're just actively burning down their joint tissue, their thyroid, and their small intestine. And by the way, if they have any neuroinflammation at all, that systemic peripheral inflammation is going to make their neurogenic inflammation much worse. Okay, so this is a loop of chronic immune reactivity. We don't know enough about this case, but we could say that this is leaning towards a chronic autoimmunity, definitely not an acute flare of it, although we could say possibly an acute flare because these neutrophils are 76%. And they should be around 63%. Remember, the neutrophils are the thing that go into the tissue to try to resolve the problem. So you actually want neutrophils elevated if you're trying to resolve an inflammatory issue. But if what they're trying to resolve is tissue damage that's from healthy tissue, because your immune system is attacking healthy tissue, that is not good. We want to try to stop those neutrophils from going into tissue. Here's another case on the right-hand side of high neutrophils. Okay, so that goes to this next slide. Okay, again, this is another person with low white blood cell count, but look at their neutrophils, 39%. They should be 60. Look at their monocytes. Monocytes should be about 4 to 8%, right? So now their monocytes, they're like Pac-Man. They just go around and they're the ones that go into tissue and they actually eat the neutrophils. So the neutrophils go in first when there's damage, and then the monocytes follow and they eat the neutrophil. And if the monocyte doesn't take care of the problem before this timer goes off, it explodes. And then you get all of this, what's called secondary necrosis in the tissue, which means rotting of tissue due to inflammation. So this person has definitely a lot of tissue debris. They have a lot of tissue damage. They have monocytes that are almost 200%, the range that I'd like to see. They also have lab low neutrophils. They've been fighting something for a very long time. They're not winning. They don't have a kidney problem necessarily. They don't have aplastic anemia or a bone marrow problem because their red blood cell count looks normal and their platelets look normal. Okay, so there's a way to actually look at these labs and go, okay, you know, without teaching an entire blood chemistry course, the idea is like you look at this and go, okay, clearly this is out of range. Clearly, if they have antibody testing that says it's negative, we can't really. That's like saying that there's low bacteria in a fish tank that's empty because there's no water in it. Okay, oh, there's no fish in this stream. Yeah, right. There's no fish in the stream because there's no water in the stream. Okay. So if there's no white blood cells, then there's going to be fewer antibodies. And by the way, if this person has an antibody elevation, they really have a problem. Okay. So something to consider there. That's what that looks like in a chronically activated person. This person on the right, actually, see if I can make this a little bit bigger. This person on the right, you can see their neutrophils are 71%. This person had a death in the family, I think a vaccine and COVID. This is a couple of years ago, all at the same time, and then started getting excruciating shooting pains at night when she slept, and significant SIBO and significant bowel issues as a result of that. She also had elevated LPS in her bowel and her array 2 testing. So she had basically neurogenic inflammation, which is a loop. She had chronic immune activation leading to infection in her gut, which was a loop. She had autoimmunity, which was another loop. So gosh, that's what that looks like for that person. And for that person taking, where'd it go? For that person, sorry, I have to jump around so much, folks. I think I lost my slide here. For that person, an anti-inflammatory fat for the brain really made a pivot point in their case, but we weren't able to resolve everything in short order. Like, we're still working on stuff, okay? Now, this looks pretty decent. That's white blood cell counts 5.2. You can see this person also has macrocytosis. Look at the neutrophils, 40%. Okay, the lymphocytes, 45%. So this is too low. Okay, so this is a person that basically, let's say they had normal, let's say their MCV was 96, not 98. Their lab would flag as normal. It wouldn't flag at all. Okay, but this person has long COVID. This person had vertigo. This person had feet that turned white and purple. This person had ear issues where they had eczema in their ear or infections. They've had like 4 ear infections since they had COVID for the second time. They've had the flu, they get chronic infections. This person cannot resolve infections. Now, they used to have high TGF beta. We're going to get into that last loop here. Okay, TGF beta here in a second. I've been talking about and saving that for last. But basically, let's say that this person here wasn't another person. Let's say that was the same person here. I would be stoked if this person went up to 5.2 from 2.7. I would be so happy. Okay. But this person could feel worse. Why? Well, what if their white blood cells became more abundant, but their autoimmunity wasn't mitigated? So now the more abundant white blood cells were more effectively attacking tissue. Do you see how complicated this can get? Okay, so you can't just look at a lab and go, you're better. So this goes to the kind of like what clinical practice is like. I want to share this with you folks because you're like, well, look, can I just do a 15-minute session with you? And I'm like, maybe. Okay, but I actually need to look at this lab. I need to look at your old labs if you have them. I need to talk to you about what we did. Okay, but not what we did. I may recommend 3 supplements and 2 brain exercises, extra sleep, avoiding gluten, if this person had to avoid gluten. And then, okay, that's my recommendation. What percentage of people follow my recommendations that we talked about? 100%. Almost none. Okay, some people do. Okay, this person's awesome with most of her recommendations, but I need to know, okay, when you titrated up on supplement A, how many did you get to? And then what was the symptom you got when you found out it was too many before you subtracted 1? What did you do on supplement 2? How did you do on supplement 3? The same set of questions, okay? How has your sleep been? Okay, how is the stuff going on in your ears? Okay, I need to check in on every single symptom. And then I need to go, what's left that's hanging around? Okay, and how close are we to your goal? And in order to do that and look at all those different labs and then talk about, well, let's say one of those supplements didn't go well. Okay, I need to figure out what was the symptom, why did they stop it, how long did it last? And you can't do that in 15 minutes. I need minimum 30 minutes to get through some of this stuff. And it's okay, but sometimes people think I'm just like, I don't know, none of you, of course, okay, but I get some feedback that people are like, do I really need, 45 minutes to talk to you? And I'm like, if we don't need it, we won't take it, okay? But like, yes, if I'm recommending 30 minutes, it's because we need 30 minutes, okay? If I'm recommending an hour, it's because we need an hour. And it's not because, I want to book an hour. It's because that's what I think we're going to need. And by the way, I can talk at like 50% the pace that I'm talking right now, okay? I could talk 2 or 3 times faster than this. In fact, I have. Okay, sometimes when I teach seminars, I'm getting to the end of the seminar, I need to go really, really fast. Okay, but the idea is if I'm going really fast, what is the client going to get out of that? The good thing about this seminar is recorded. You can watch it again and again and again, and you can slow it down. But the idea is you can't rush this stuff. Okay, and my job isn't to fix labs. My job is to help a person create conditions that are right so they can heal. This person has macrocytosis. They cannot deliver oxygen effectively to their tissue. More importantly, their brain. Are they in the right position to heal? 100% no. Okay. Is this going to affect every single thing that we're trying to fix? 100%. What do we need to do to fix this? I don't know. Is it a B12 issue? Is it a folic acid issue? Is it a stomach issue? Are they vegetarian? Okay. Are they vegan? Okay. I know what's going on with this case, but do you see now I need to go through that entire list of questions for this one little finding, even though the rest of this looks normal. But if this person who had white blood cells of 2.7 now has white blood cell 5.2, I'm thinking we're making progress. Look at 97 to 98. Okay, but this hasn't moved at all. 39%. This is like now 40%. But look at the monocytes. Down from 15% to 9%. That's less tissue debris. I get pretty excited when I see less debris. That means less tissue damage, less potential for autoimmunity, and that means that they're starting to rally. Unless they've just lost their capacity, but her capacity has gone up because her white blood cells have gone up. Do you see what I'm getting at? Now, where we started was she had almost triple the range, well, somewhere between double and triple the range of TGF-beta. Now, this gets into the loop of COVID, loop 4, which is basically fibrosis. Now, I'm going to spend about maybe 10, 15 minutes on TGF-beta. Just Google TGF-beta after this call, after this webinar. Google TGF-beta and you'll be like, okay, now this test is like $16 through LabCorp. That's the deal that we've been able to get people, is $16. It's worth its weight in gold, to the point now where I just do this as baseline. TGF-beta goes up when cancer cells are abundant. TGF-beta goes up when we have a bunch of scar tissue formation happening or a bunch of inflammation resolution happening. So let's say you had a surgery or something and you have a ton of white blood cells that are now inside of tissue resolving that injury. It's appropriate to have TGF-beta going up, okay? But when TGF-beta goes up, it suppresses the production of a chemical in our body called, or a protein, a tri-protein amino acid called glutathione. Now, if you've taken one of my seminars as a clinician, I've spent an entire weekend talking about glutathione. And basically, glutathione does liver detoxification. Glutathione, if it's the best way to pull the pants down, like de-pant, you know, that old prank where you pull somebody's pants down, okay, and expose their underwear, like that old high school gag that people do. Okay, the best way to de-pant the brain is to basically drop glutathione levels. Glutathione also basically is a major antioxidant, so it quenches free radicals. It can help chelate heavy metals out of your body without penetrating tissue, which is super important. But it's very difficult to make. It's 3 amino acids, and in order to make it, you have to have really good blood sugar, which most people don't. You have to have really good protein digestion and absorption, which most people don't. And you can chew it up very quickly because free radicals, or basically aging or energy production, chews that up. So imagine like a bunch of furnaces in your body called mitochondria making energy. They release heat and they release exhaust. That exhaust creates free radicals, or is free radicals. Those free radicals damage the DNA. And when the DNA is damaged, we're more likely to express oncogenes or cancer genes. We're more likely to express inflammation, and it's basically trying to kind of slow us down or make us aware that there's a problem if we're not able to quench these free radicals. These free radicals are what, like, if you ever look at a triathlete and you're like, wow, that person's like in their 30s and they look like they're in their 50s. It's the free radical damage from the sun and like overtraining that can damage their skin. It's free radicals that basically is what is aging us, but free radicals are a part of life. It's not just good enough to say we take a bunch of antioxidants, because that can polarize the immune system into a bad place. So-called anti-aging medicine uses a lot of antioxidants, okay? And those antioxidants actually can be dangerous, and they actually can suppress the production of glutathione. Anyway, I'm getting off track. My point is when you have high TGF-beta, you have an increased risk for cancer. Now, this person didn't have cancer, but there's another person that I'm going to show later with TGF-beta that did have cancer. I had another client in this morning who is recovering from long COVID. He's doing so much better. He had mucosal cancer. He had cancer inside of his mouth. And he had high TGF-beta when we ran his baseline test for COVID. But he had cancer years ago. And I'm guessing he had high TGF-beta this whole time. Okay. But when you have high TGF-beta, that also can be secreted by what are called myeloid-derived suppressor cells. If we go back to that loop 2 of loop 3 of COVID, which is long COVID, which is neurogenic inflammation, remember that the nerves can secrete something called VIP, and that VIP can tell the bone marrow to start pumping out ILC2. ILC2 causes these myeloid-derived suppressor cells to be made in the bone marrow, and then they release TGF-beta. Why is the body doing this? Because you're freaking inflamed, okay? And your immune system is freaking out. So you start making all these myeloid-derived suppressor cells to try to get in and calm everything down. But just like any other process, it can go off the rails. Now, there's really no easy way to measure myeloid-derived suppressor cells. And there's really no way to know exactly why you have elevated TGF-beta. You can take a history and you can kind of work through that, okay? But you can take it to the bank that if your TGF-beta is elevated, you're going to have more free radical production. And if you have neuroinflammation, which is basically a permanent change to your white blood cells in your brain from a blow to the head or a significant psychological trauma or significant infection, then these free radicals will hit those cells in your brain and they'll give you brain fog, and they'll give you depression, they'll give you anxiety, insomnia, numbness and tingling, pain. And then you end up with neurogenic inflammation and the histamine release and the pain and the migraine and all that stuff downstream that we've been talking about over and over and over again since I started these COVID videos. So when you see elevated TGF-beta, you're like, okay, this person probably is producing free radicals. They're undergoing accelerated aging. They're likely creating more scar tissue that's permanent. They never get that back. It's permanent. Fibrotic changes. Okay, this is a 19-year-old girl undergoing permanent fibrotic changes who has celiac, who has dyslexia, and who has an autoimmune condition that's affecting her blood and her circulation. How much longer do we want to wait before we jump in? Do we wait till she can't walk? Do we wait until she has vertigo so bad that she can't drive or go to school? Okay, when do we want to dive in? Okay, now, if you're taking things like to try to help your body fight autoimmunity or regulate your immune system for autoimmunity, you kind of want TGF-beta to go up. You don't want it low for sure. Okay, to fight infection, you kind of want it lower, okay, or normal. To not have autoimmunity, you want it normal. And if it's high, that might be in one way good for autoimmunity, but another way it's really not. So we just need to drop that idea, because TGF-beta, when mixed with stress cytokines, can cause activation of those white blood cells that carry out autoimmunity. I know I'm talking really fast, but I don't know how else to get this in, okay? So this TGF-beta is a really big deal. And what happens to people sometimes is when they take antioxidants or they take glutathione or they do something to lower TGF-beta, they feel worse. Okay. And so they feel worse maybe because now their immune system is going after the infection that has been like just waiting in the wings. One other reason that we have elevated TGF-beta is because, I'm looking at the time, is because pathogens love being in our body. They're like, this is amazing. They get in your body and they're like, I like it here. This is like cool. Like, you know, I think I'm going to move here. I want to set up camp in this tissue over here. And we're going to start procreating. We're going to make a little dome and hide under it. So, you know, if we're going to basically squat here and we don't belong, but if the sheriff comes by, we're going to actually maybe kill the sheriff and eat the sheriff, which is basically killing the natural killer cell to try to eat it to survive. That's something this infections in the small intestine do a lot, and large intestine. And, you know, we're going to actually pay off the immune system so that they basically don't want to root us out. So they become organized crime inside your body, and they have a relationship with all the cops, and the cops are basically looking the other way. So that's one reason we have elevated TGF-beta. So when you start lowering TGF-beta, with whatever your interventions are going to be, they may actually go through a healing crisis. They may get a fever. They may get swollen lymph nodes. However, if you lower TGF beta and they have autoimmunity, they may get an autoimmune flare if other factors aren't in place first. And I can't go through what those factors are, folks, because that's another, 2-week seminar or 3-week seminar. It's going to be different for every single person. Can you see how this map is starting to look different for everybody? And that's why the name of my clinic is Atlas Health, because it's a book of maps to figure this stuff out. So the moral of this story with TGF beta is when this is elevated, you're undergoing permanent tissue fibrotic damage. And if you say, for example, have kidney disease and your kidneys are already in grade 2, grade 3, grade 4 kidney disease, you don't want this elevated. You're going to have permanent loss of kidney function that doesn't come back. That means your EGFR may never come back to normal. Okay, we want to make the buck stop here. If you have cancer, it may be harder to stay in remission. If you have Epstein-Barr virus, cytomegalovirus, if you have shingles suddenly, a lot of people get COVID and they're getting shingles. Okay, a lot of people are getting COVID and they're getting their yeast infection back. A lot of people are getting COVID and they're getting chronic sinusitis. A lot of people are getting COVID and their Lyme is coming back, all their Lyme symptoms, because this resolution chemistry, the body trying to resolve the inflammation from COVID, led to kind of an unbalanced resolution leading to elevated TGF beta, allowing basically all these infections to run amok. And those infections running amok infect tissues. And so now we have to sacrifice that tissue. And so now you have infectious debris running around and you have tissue debris running around, and your immune system may grab a piece of that tissue debris and go, huh? And it goes to the lymph node and you can get autoimmunity from that, new autoimmunity. Okay, loop 6. So the person with TGF beta elevation definitely has loop 4 going. Okay, they have loop 5 going probably, and they're likely to develop loop 6. And they get permanent, irreversible aging. So when I see TGF beta elevated, I like drop my pen. Okay, now, working with people with elevated TGF beta, working with people with infections, working people with inflammation, they absolutely can feel worse before they feel better, because we're actually resolving infections. You might feel sick. Okay, but what you don't want is new autoimmunity, and you don't want a flaring up of existing autoimmunity. Those are things that are not, we'll just say we're not going to abide that. Okay, but if we abide a fever and a healing crisis, that's one thing. Okay, here's another person. This person has has a mother that passed away recently of kidney failure. Her kidneys are also not doing very good. She's much younger. She's in her 50s. Okay, her mother just died last year, and she has a bladder infection that cannot resolve. She also has tissue debris over here, high monocytes. She has low normal white blood cells because she's fighting something chronic. Okay, so what loop is this? Okay, this is the mucosal lining loop, loop 1. This is the chronic infection loop. Okay, and she also has Hashimoto's, so this could be chronic autoimmunity loop. That's loop 6. Okay, but look at where we were. We did these labs in January. Okay, she had elevated homocysteine, 17.8. Homocysteine is something the liver makes. It's supposed to convert to glutathione. It's extremely toxic to the brain and blood vessels. It can cause cardiovascular disease, and it basically is correlated with cancer because you need to do something called methylate in order to take care of homocysteine. So her homocysteine was lab high. Like 6 weeks later, it's still outside of the functional range, but it's now normal. That's very exciting. Okay, so this person's less likely. Oh, by the way, she has cancer. She had skin cancer, so she's showing signs that she's going to be less likely to get skin cancer. This was her TGF beta. Again, another person with cancer that had high TGF beta walking in my office. Look at it now. Okay, that's pretty cool. That was like 6 weeks. Here's another case. These are 2 different cases. I'm seeing a ton of this. So if you have high TGF beta and you had mono as a kid, which most of us did, if you get mono when you're really young, you almost don't notice it. If you get mono when you're older, it can put you in the hospital. Okay, you have all these people with myalgic encephalomyelitis or chronic fatigue syndrome, and or like chronic food sensitivities, chronic concussion symptoms, and they just can't get over. This Epstein-Barr early antigen means that they had a lytic phase or an activation of an old virus. So it's kind of like you fight the virus off. It's like if you watch Star Wars, it's like the Emperor. He's I'll be back. Okay, he kind of shrinks away into the shadows. This virus goes into the DNA. It lies dormant until conditions are perfect. Like, for example, after a COVID infection, and your TGF-beta goes up, and boom, now it flares up. And then suddenly you're getting all these food sensitivities. You're getting a sore throat. It isn't strep. You're getting swollen lymph nodes. Nobody can figure out what's going on. We do an Epstein-Barr early antigen, and it's high. Now, we go back to that story. Okay, now they have Epstein-Barr early antigen. Can this person tolerate supplements that take care of it? Can this person tolerate the medication that takes care of it? Okay, what is this person's brain doing? Do they have saccadic latencies? Can they pursue? Do they have any vestibular imbalances that we can identify, like with diagnostics and goggles and balance testing? And if they do, and they don't tolerate supplements, then we might need to do some things that help them with stress chemistry and their brain first, as a first order of business. Okay, does this person have diabetes? Folks, you're never going to fix somebody that has a chronic infection if their blood sugar is that high and they don't manage it. Okay, we're not going to be able to successfully manage their Epstein-Barr if they have high TGF-beta. That becomes the first step. Okay, what if you have high TGF-beta and you can't even tolerate glutathione, even though it's clear that you need it? Okay, that's a number of people. So we have to have a way of figuring out how to do that stuff. If you're disappointed that I'm not going through how to do that, it's because every case is different, and I can't say how we're going to do it every time, okay, until we get in there. Okay, now, this is a test. This person had migraines and severe insomnia. Okay, now look, no acute inflammation on CRP, but look, their ferritin's high. That's iron. So when your iron levels are, when your ferritin levels are high, your body's like saying this: we have iron, we want to pull it out of the blood and put it into storage because it's rusting from oxidative stress. So we don't want it to rust, because that is like one of the worst things for the brain. That and black mold are like the two worst things for the brain. Okay. So we got to get this iron out of the blood. And so we turn it into ferritin. So this person probably needs antioxidants, but this person also may not tolerate antioxidants. Okay. But what does oxidative stress do to somebody with neuroinflammation? It gives them migraines. It gives them insomnia. It gives them brain fog. It makes them hurt. Okay. This person cannot tolerate supplements. And I learned the hard way. I kept trying supplements, and we just could not, I couldn't get it through my skull that this person didn't tolerate supplements. And I almost lost them as a patient, but thankfully they stuck it out with me. We're no longer, well, we did recommend not really a supplement, but more of a fat, which is food, okay, to help neuroinflammation. But we're trying to stay away from supplements with her. And she has, this is a test called Cyrex Array 5. She had autoimmunity to phospholipid, which is the cell wall in every single cell in her body. Cytochrome P450, which is liver. This is why she reacts to everything. Okay, and azoganglioside, which is basically brain autoimmunity and central nervous system autoimmunity. It helps tend to myelin. Okay, so basically a lot of her insomnia, her chronic digestive issues, her migraines from the top down are basically from neuro autoimmunity and systemic autoimmunity. And she was in an acute phase when she came in. And the things that I would like to normally do to lower acute phase reactants, she reacted to all of them. She couldn't take them. And she had all these histamine issues. She couldn't tolerate things that block histamine. So basically right now we're just trying to work with her to help her with deal with this stuff using like fitness, band exercises for her hips, if you can believe that. And she's making some interesting progress. She's also doing keto, which is pretty cool. By the way, I don't recommend keto for everybody. I'm not a zealot, okay? But keto is amazing for a lot of people, but keto is actually terrible for a lot of people too. And you absolutely can do keto wrong. And so I'll make an entire another video on keto. Okay. This test here is like $575. Okay. It's an expensive test, but it's worth its weight in gold. I can tell you, if you've had if you've had COVID and you're not feeling right, and you're not sure if you have autoimmunity and you're having neurological symptoms, it's really helpful to know if we're dealing with neuroautoimmunity or if you have other cells that are being attacked by your white blood cells. Okay. A lot of people with heart symptoms have myocardiopeptide. A lot of people have digestive and circulatory issues. They have tropomyosin. Conatct is large intestine, intrinsic factor, parietal cell. That's the stomach. So people with ulcers and that macrocytosis that we saw. Anyway, this is an amazing test if you have the budget for it. C-reactive protein, I believe I can get for $16. H. pylori breath test we did with her because she had chronic digestive issues. That was like $120. Homocysteine, that's up there. That's like $70. I can't get that down. Ferritin is very cheap. Okay. A CBC with differential, which is basically looking at this test here. That's the white blood cell count. $5.50 plus like a blood draw. Pretty amazing. Okay. That we can get it for so cheap. So, okay. I know I was talking really fast there, and I'm hoping that I didn't overwhelm everybody. But hopefully motivated you to move forward with some lab testing. If you're struggling with COVID, I want you to know that it's definitely possible to figure out what these different patterns mean. But just looking at a lab test, one lab test by itself in the matter of like 2 minutes isn't going to be enough. We need to sit down. We need to look at it within the context of other lab tests if you have them, with your history, ideally with an exam, and really dive into it, okay, and figure out what are we going to do and when, what supplements might be helpful. And by the way, when you're working with a case that has autoimmunity, this is like one of the things I really wanted to cover today. So many people with COVID are in the age of COVID are wanting to stimulate their immune system. I want to stimulate my immune system. Okay. I want my immune to be strong, my immune health to be strong, which I understand. Okay. But if you want your immune health to be strong and you already have autoimmunity, what's that going to do for you? It could actually make your autoimmunity worse. You could take astragalus, or you could take green tea extract. Okay. Or you could take zinc, or you could take anything that stimulates the immune system. Echinacea. One of my favorite terrible supplements to take long-term for autoimmunity is elderberry, right? Okay, you could just totally wreck yourself with this stuff if you do the right thing, but at the wrong time. So I want you to be really careful with supplements. Of course, I have a bias. All right, I'd like people to maintain safety. I don't think supplements are safe. I think supplements can be particularly dangerous. I think people underestimate supplements. I understand why certain countries want to regulate them more. At the same time, I hope that they don't take them away from clinicians that can use them, or make it harder to use them, because that would affect my ability to help you with supplements. But they're potentially like a godsend and amazingly helpful, and potentially extremely harmful. And if you ever wonder if your supplement is causing a problem, or you take a supplement and it doesn't go well, that's the moment when you need somebody with experience to guide you through that. So I highly recommend you don't try to do that on your own. Okay. That's my recommendation there. And you absolutely can give yourself autoimmunity with supplements. I did a whole video on how iodine can cause thyroid autoimmunity. And by the way, iodine is in salt in this country. So eating a ton of salt. Have you ever noticed? I had one patient who only got migraine flares, who had brain autoimmunity from gluten, if they had margaritas with salt on the rim. I mean, that's kind of interesting, right? Okay, well, the salt triggered an autoimmune reaction, and the salt also had iodine in it. So that's a double whammy for Hashimoto's. That's how ornate some of these different history findings can be. Okay. Is there anything else I want to talk about? Okay, if you have chronic infection and you try to stimulate the immune system for chronic infection, there's going to be at some point when there's diminishing returns there, particularly if you have autoimmunity. If you have autoimmunity and you try to suppress the immune system, you could cause blooming out of an infection. So there's definitely cases that you give them things that like stop inflammation, like turmeric or resveratrol, for example, have been shown in the literature to help with inflammation. Fish oil, that person all of a sudden gets a shingles outbreak. It might be suggestive that that pushed their immune system a little too far. It doesn't necessarily mean that you're daft or that you're a wanker as a clinician. It means that we learned something from it and we actually need to modify their care plan. And that's actually a realistic clinical scenario. And if all you're doing is doing a protocol, or if you're a client and you're expecting a protocol to work and something like that unexpected happens, there needs to be a way to work through that. These long loops of COVID, yes, they're long loops of COVID, but guess what? These are the long loops of any chronic degenerative problem, okay? And COVID just has an exquisite ability to basically take those pre-existing issues called comorbidities in the parlance of disease process and make them much, 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 much worse. Same thing with the vaccine in some people. I've also seen some people who've gotten COVID and the inflammation from COVID and the inflammation from the vaccine actually help them resolve chronic issues and they're better for it, okay? So we need to kind of move out of this idea that COVID is inherently bad, okay? It can be a gift for some people, but really if you're stuck with long COVID, or if you know somebody that's stuck with long COVID, I want you to know there's absolutely a way to work through this and get you to a place where at least you can understand the framework of what's happening. And with that understanding, the interventions can start to reveal themselves as we look at how you've historically responded to the different interventions that are available. Basically, a large number of people are on the cusp of developing chronic conditions that don't know it. And so a lab test like a CBC with differential, CRP, homocysteine, a couple different vitamin D tests, and TGF-beta, if I didn't say that already, that testing can really, from a lab perspective, give me a really good window into these different loops of COVID. And that combined with the history, and especially if we have the benefit of an exam, we can really turn this COVID thing on its ear. And I think this model of identifying physiological problems as a driver of disease and dealing with it ahead of disease actually could be preventive, which is super, super cool. And I'm just something I'm really excited about. So I really appreciate your time tonight and allowing me to share this with you.